Everybody, I am Peter Schwartz. I'm the director of the Bioethics and Subject Advocacy program of the Indiana CTSI. I'm the director of the Center for Bioethics at IU, and I'm very honored to host this series, the Translational Research Ethics Applied Topics series, known as TREATS. These are short presentations, and Erika is short, and she will keep it short if I know Erika. Dr. Cheng, I should say, who will be talking to us today about participants in clinical trials and encouraging and enrolling and expanding our view of participation in clinical trials. And I'm thrilled to have Dr. Cheng here today. She is most relevantly a faculty member in the BSAP program, the Bioethics program of the CTSI, and has been for more than a year now, and we've been very lucky to have her. She's also an epidemiologist, expert in public health, a health services researcher. She's in the Division of Children's Health Services Research, director of the CHSR Fellowship Program at IU School of Medicine, and is executive director of the HEALER program, which is Health Equity Advancing Through Learning Healthcare Systems Research, which is run out of IU Health and is a very important force on campus for encouraging people to enter clinical research and people from all backgrounds to do that. So we're thrilled to have Dr. Cheng here today. She's agreed to do our TREATS talk. Again, these TREATS talks are recorded and they are posted on our website with a link you can find easily, actually, and soon to be on the CTSI website with additional materials you may want to look at to learn and expand your understanding. And if you have additional questions, please write to me or Nick Oliver on here or directly to Erika to ask for help. We do that through our bioethics service at the CTSI. So without any further ado, because there has been plenty of ado so far, I will stop and hand the microphone over to Erika. Dr. Cheng, thank you.
Thank you, Peter. That was a very nice introduction. I really appreciate it. I am short, but I did think that this tree talk was supposed to be an hour. So I have a lot of slides, but I will, I don't really like talking for that long. And so I would love to be interrupted so that we can talk about other things or talk about things within this presentation. And I will also rush through some fluff to get to sort of the meat. So as Peter said, I'm Erika. I'm really excited to be here. We're going to talk about today this sort of deceptively simple question of who should participate in clinical research. So, spoiler alert, it's not just about recruitment. It's also about equity, ethics, justice, making sure that what we learn in research applies to everyone. Now I cannot advance my slide. Oh, okay. So we're going to explore the importance of population representation and participation in clinical research. We're going to talk about why representation in clinical trials matters. We'll walk through some historical and ethical contexts about the current state and why we're here, who's left out, examining barriers to understand why people are left out, and then we're going to explore some strategies, some promising strategies, some that are still evolving for building research systems that are inclusive, representative, trustworthy. So, to begin, we all know, we're all here because we know that clinical research trials play a really critical role, pivotal role in advancing medical treatments and enhancing healthcare outcomes. Globally, clinical trials contribute enormously to progress in treating and preventing disease, overall life expectancy. And these, I'm talking about trials and where people volunteer or are recruited as participants to help researchers find answers to specific questions about how health, disease, and therapeutic interventions work. Maybe some of you have been involved in a clinical trial. Maybe some of you have led a clinical trial. So you know that the data and the evidence from these studies generate, evidence and data that are critical for ensuring that there's a fundamental discovery and that it translates into improvements for human health, for securing reimbursement and therefore patient access to therapeutic interventions. So, despite how important clinical trials are, there are a lot of issues right now, particularly with what. And this is important. I'm going to talk about what I mean by diversity in just a second, but this is important because our ability to protect and improve health is limited if there are huge parts of the population that, and oftentimes people with the greatest health challenges or the most premature mortality or morbidity, if they're less able to benefit from these discoveries because they're not adequately represented in clinical research, then that's a problem. So we've made some progress. So here's what I'm talking about when I'm talking about representation. I'm talking about all these little dimensions of representation. So race, ethnicity, age, socioeconomic status, disability, nativity, language, sexual orientation, childbearing potential, gender, rurality, urbanicity. So we've made some progress in areas. So, for example, the participation of white women in research studies, clinical research studies, has greatly improved and increased over recent decades. But there are lots of groups that still remain systematically excluded. So racial and ethnic minorities, pregnant people, lactating people, older adults, rural communities, LGBTQ individuals. I think so the census in 2020 found that the proportion of US adults who identify as white is no longer the largest group for the first time since the census has ever been taken. So I'm not talking about like fringe groups. These are groups of people that represent a huge proportion of the population. And so excluding them from clinical trials really undermines both the scientific validity of the study and the equity of how those studies or how the findings are going to be applied. And why does this matter? So when trial participants don't reflect the broader population, we end up with treatments that work for some people, but not all people. A lack of representation can shift the direction of research more towards majority groups, and this can actually lead to worse outcomes. It can widen disparities. It contributes to mistrust in medicine, and over time, this exacerbates outcomes and disparities that we see. So, failing to adequately represent underrepresented and excluded participants in clinical trials, it also limits scientific innovation, which we'll talk about in a second. And they often, when there isn't a representative approach to recruitment, you might not recruit as many people as you need, and the study could fail. This is very expensive. It leads to a lot of high costs, a lot of missed opportunity costs. And we're going to talk about how because this is BSAP, we're also going to talk about how it's very unethical. I'll skip this one. Okay, so when trials don't include diverse groups, we can't make evidence-based recommendations for those groups. So this has actual consequences. So here's an example in colorectal cancer. In 2021, the U.S. Preventive Services Task Force released new guidance for colorectal cancer screenings. So in the United States, Black adults have the highest rates of incidence and mortality for colorectal cancer. But they don't have differential screening recommendations because the USPSTF admitted that they didn't have enough evidence to recommend earlier colorectal screening for Black adults. So there's sort of as a result, there's a uniform screening that starts at 45 for everybody, despite the fact that the risk for a variety of reasons, which is not the focus of the talk, but the risks are unequal. But there wasn't enough evidence to justify, from the perspective of the USPSTF, to justify differential screening ages. It's not only about fairness, including diverse populations also leads to better science. So this is an example from a study that was published in the New England Journal about a gene called PCSK9. So one of the things that is to me concerning about people not wanting to look at differences in outcomes is that some of the most important discoveries that we have come from exploring variation and differences in outcomes and predictors. So this gene, this PCSK9, is a gene that's critical to cholesterol metabolism, which I don't really know a lot about, so don't ask me. But and this finding came from the Erika study, which was a study that intentionally included Black participants. They over-recruited for Black participants. So they found this mutation and this gene was identified in about 2.5% of the Black participants and in just over 3% of the white participants. And the mutations, when they looked at the impact of the mutations stratified by race, they found that there was an 88% reduction in the risk of cardiovascular disease amongst Black subjects who had this gene versus only a 47% reduction for whites who had the gene. white patients. So, without including the overrepresentation of the Black adults and stratifying the results to look at how there might be differentiation in the impact, the researchers might have never discovered the mutations of this gene and how they're linked to lower cholesterol. So this finding helped create a whole new class of drugs for cardiovascular disease, therefore accelerating innovation and improving health. So, okay. So let's see. So we also know that trials without inclusive strategies for recruitment they often fail to recruit enough people to complete the study. More than half of clinical trials that are terminated are due to low enrollment. And low enrollment is the #1 reason why clinical trials aren't completed. When you have an underrepresentation of diverse population, it contributes to this failure. So when you have really narrow eligibility criteria, lack of trust or awareness in marginalized communities, trials held in locations that are inaccessible to underrepresented groups, you're going to have fewer people eligible for your trial, fewer people engaged in your trial, and therefore contributes to a waste of time, funding, opportunity, and inability to engage your participants in your trial. Some participants, the only way that they can access potentially life-saving treatments is by participating in a clinical trial. So when trials exclude certain groups, they're also excluding them from access to this innovation. And this, as I mentioned before, can sort of perpetuate disparities, widen inequalities. And we see this a lot in fields like oncology and precision medicine, where there's these really innovative, cutting-edge findings that are happening. And if there isn't equal representation in your study participants, there's also not going to be equal representation in who has access to these innovative therapeutic strategies. And then, inclusion in trials, I argue, isn't just a cost, it's also an investment. So this one study that came out from recently about representation in clinical trials, they estimated that eliminating racial and ethnic disparities in diabetes, heart disease, and hypertension, so 3 of the leading chronic conditions that we see, it could yield about an $11 trillion value in society by closing equity gaps, increasing life expectancy, and decreasing the burden of disease. So this sort of implies that equitable representation in trials can extend lives, improve health, lead to a lot of value and a lot of economic value. And so this is sort of the value of building a research system that serves everyone and not just the few. So because this is BSAP, we should talk a little bit about the ethics and what the ethical foundations of inclusion are. So this quote is from the Belmont Report, which I think you are all familiar with, that says the selection of research subjects needs to be scrutinized to determine whether some classes are being systematically selected simply because of their easy availability, their compromised position, or their manipulability, rather than for reasons directly related to the problem being studied. So this quote crystallizes sort of the ethical roots of today's conversation about representation in research. It emphasizes that who we choose to study and who we leave out is not ethically neutral. And that vulnerable populations have been historically exploited or excluded based on, convenience or perceived compliance, not necessarily about scientific relevance. And so even though this was 40 years ago and the Belmont Report cautioned against this, the patterns that we see still exist. So the Belmont Report laid the foundation and the groundwork for principles and guidelines for research involving human subjects, and identifies 3 basic ethical principles for human subject experimentation. So respect for persons, beneficence, and justice. But when underrepresented communities are systematically excluded from clinical trials, I think we're failing on all 3 fronts. So respect is compromised if people aren't given real opportunities to participate. Beneficence breaks down if we don't understand how interventions work across populations, then we are not maximizing benefit for all. And justice is violated when research risks and benefits are distributed unfairly. And so historically, justice in research meant avoiding exploitation. So avoiding exploitation for people like prisoners, low-income individuals, minoritized and marginalized communities. And that's still really important to protect vulnerable groups. But I think today we also have to ask, are we denying people the benefit or the chance to benefit from society? And is that, I think that's like a lens of justice that needs to be discussed more. So justice in this context means making sure that people from all backgrounds can participate and benefit from research. So otherwise, I think we risk reinforcing or worsening disparities that already exist. So this would include asking questions like who gets offered trial participation, who lives near research sites, who can take time off to participate. And in terms of grant funding, I think there's a clear argument that publicly funded research has to serve the public, and that means building systems that don't exclude swaths of the public by design. So okay, so the Belmont report was written in response to these like ethical failures, like the Tuskegee study. And then the common rule, as you all know, it's the regulatory backbone of how human subject research is governed in the US. So it applies to all federally funded research involving human subjects. It outlines informed consent, IRB policies, protections for vulnerable populations like children, and requirements for equitable selection of subjects. So the common rule specifically states that IRBs must ensure that study populations are chosen fairly, considered with the purposes of research and in the setting in which the research will be conducted. So there is, something about equity of human subjects research participation in the common rule. But there is no specific mandate requiring researchers to include underrepresented populations unless their exclusion is unjustified. So it's more about protecting research participants from harm. And the language mainly focuses on preventing harm and protecting people from harm and giving clear guidance about consent, oversight, special protections for vulnerable groups. But the common rule and the Belmont report, it wasn't really built to promote equity, which is a different way to look at it, right? It doesn't require inclusion. It only cautions against unfair exclusion, if that makes sense. So in practice, it's often interpreted in ways that actually reinforce exclusion. So when IRBs prohibit non-English speakers from participating because their translations might be too complex or too costly, or they say you can't include pregnant people because they're a vulnerable group, then you're actually excluding groups of people from research that could benefit from the findings of the study. Does that make sense? Does anybody have any questions?
That
So,
makes great
yeah.
sense. That makes terrific sense. You covered some questions I was going to have. So wonderful.
Do you want to chat about it? We can stop and chat about it for a minute. Or
Well,
do you
I just think you did great at highlighting. I'm sorry. Let's talk at the end. But I love that you highlighted the issue of protection versus exclusion, right? Protection has been the goal of research ethics for so long. Protection of the minoritized, the vulnerable, the poor. But that leads to just what you're saying. So I love that point. Thank you.
I think that's sort of the key ethical part of this conversation, which is the most relevant to this group, is just how can we evolve from the Belmont report, which focused on protection and set up IRBs to enforce protection and inform consent and mitigating risk. How can we move from that to sort of making sure that we also pay attention to inclusion, access, and equity? So, is that through, and there's some strategies I'll talk about later, that include community partnerships and power sharing, awareness of sort of the structural barriers to participation in clinical research, and then equity as a design principle as being built from the beginning instead of an afterthought. So just to go over sort of where we are in terms of clinical trial representation. So, despite like I said before, despite representing a large proportion of the population, there's a lot of minoritized groups that are significantly underrepresented in research studies. So this includes racial and ethnic minorities, rural populations, those experiencing social disadvantage. We know that Black and Hispanic populations continue to carry a disproportionate burden of disease. They're more likely to have cardiovascular disease, for example, obesity leading causes of morbidity and mortality in this country, but yet they're very underrepresented in clinical research. Rural residents, low-income individuals, non-English speakers, they're much less likely to be enrolled than their counterparts. And then this mismatch between who's sick and who's being studied is very real and is sort of a persistent issue that we've seen in research over many decades. So here's a chart that highlights the mismatch between racial and ethnic makeup of the US population and participants enrolled in clinical trials. So you can see here the orange line represents the percentage of people that are in clinical trials, and well, they're both orange, I'm sorry, and the yellowish one is the reflective piece of the US population. So white, for example, people who identify as white make up approximately 60% of the US population, but among clinical trials, over about 75% of clinical trial participants are white. So if you look at Black and Hispanic, you can see that they are being underrepresented in clinical trial research, where you have about 16% of US Americans identifying as Black and fewer than 10% of clinical trial participants identifying as Black. It's not just about race or ethnicity. There are also geographic differences that we see, especially in rural areas. So, 1 in 5 people in the United States lives in a rural area, which I actually didn't realize was so many. And about 5% of people who are involved in a clinical research trial are from rural, I'm sorry, about 5% of trial sites are located in rural areas. So if you want to participate in a clinical trial, but it's in an urban setting and you live in a rural setting and it's hours away, you can't take time off work. So you're functionally excluded from being able to participate in that trial. So I think, and the same is true with low income participants versus the low income population. So I guess, basically what I'm saying is that we need to stop assuming, not that anybody on this call is assuming, but I think there's been an assumption that underrepresentation is about willingness to participate, but it's not, often it's more about access than it is about willingness. In fact, when studies consistently show that when you ask people if they want to participate in studies, they do want to participate in studies. Silk Soto's work with All In for Health showed that beautifully, is that when asked, people are like, yeah, sign me up, but they're not often asked, or the trials are not accessible to them. So there's progress, which will be interesting to see. I don't know that, so there's some progress happening. If you look at NIH-supported trials, reporting of race and ethnicity is more common, if not, required in some instances. If you look at that, so let me see. So in here, there's NIH trials are on the right side and industry-sponsored trials are on the left side. And it's showing the publications that include minority participants for NIH-sponsored trials versus industry-sponsored trials. And you can see that there's, for many industry trials, there's like a lag, not many publications include minority participants in them versus NIH trials. So this is important for many reasons. I think that it's showing that the data on participant demographics is being reported so that people can be held accountable. When you don't report those data, there's no accountability. And if there's a lack of transparency, then you can't really look at inequities in research and who research is serving. So, if you ask why are so many populations underrepresented in trials, it's not because people don't care. As I said before, it's not because people are hard to reach. Evidence shows that communities are very willing to participate if they're invited and when the conditions are right. But the truth is that there are a lot of barriers that are structural, relational, but they're also, in my opinion, fixable. So here's a figure from an article that was published in the Journal of the American Heart Association, and it illustrates that barriers to research participation exist at multiple levels. So I think the takeaway from this figure is that barriers exist across a broad spectrum. So at the interpersonal level, for example, people might not trust the system, they might not feel respected or welcomed. At the institutional level, trials are often designed in ways that unintentionally exclude groups of people. And at the policy level, structural inequities like who gets funded, where trials happen, continue to shape access. So improving representation in clinical trials means working across all of these levels at the same time. And here's another way, if you kind of zoom out to understand, for those people here that are more theoretical, to help zoom out and understand the big picture of why certain groups remain underrepresented in research. So it's not just one thing. It's not just, oh, this person mistrusts the system, or, oh, this person's unaware of the trial. The barriers to participation exist on multiple and interconnected levels. So we need to address multiple of them, or we won't be able to move the needle. So at the interpersonal level, patients are often navigating sort of historical mistrust, poor communication with providers, feeling excluded from the research conversation. So this is where concepts like psychological safety come in. Do people feel respected? Do they feel valued? Do they feel safe enough to say yes or to say no? And then at the institutional level, we see trial sites that are physically or culturally inaccessible, research teams that don't reflect the communities that they serve, protocols that unintentionally exclude entire populations, like you have to be English speaking. And then finally, at the policy at a systematic level, at the institutional level at the top, we face structural barriers. So who gets funded? How are trials approved? What gets reported? And is there accountability? So, this figure and the figure before reminds us that it's not about just building trust, although I think that's a really important thing. We also need to sort of build an infrastructure that includes policy and organizational policies and cultural competence that support sort of equitable inclusion across across research. In surveys and interviews, participants, patients, and community members, they often say the same things. If you think about the personal levels, personal factors, they don't have enough information about trials. They're unsure if they'll be treated fairly in trials. There's logistical barriers like transportation, childcare, time. These are all deal breakers for them, but I think that they are solvable problems that you can build into your research design and not only realize after the fact. So here's another patient level barriers sheet. So, I think like even if patients are interested or people are interested in participating in your study, there's daily life that gets in the way. So transportation, work, caregiving, all of these affect an ability for a person to say yes to participating in a trial. So, imagine trying to join a trial when you don't have a reliable transportation, or when the site is only open from 9 to 5, or you don't see yourself represented in somebody in the research team. Nobody speaks your language. Nobody looks like you. These aren't hard to reach patients. These are systems that are hard to engage with. Oh, sorry. Okay. From a provider and system level, providers often assume that patients won't be interested and they won't comply, and sometimes they don't bring it up. Others might lack awareness about studies or face institutional constraints. Peter can talk a little bit more about this. We're finding that's out in our current institution, that there are a lot of clinical trials going on that are recruiting patients, but patients, providers aren't always aware that there is a trial that exists. Patients aren't aware of how they can get involved. Sometimes clinicians don't bring up trials because they assume the patient's not going to be interested. They assume that the patient won't follow through with what's going to be involved. Often the clinic lacks time, staff, infrastructure to approach a patient and invite them to be part of a clinical trial. And when protocols are designed without inclusion in mind, they exclude by default. This is about provider perception and bias, which I just kind of chatted about how some, there's evidence to show that providers believe that some patients are less likely to adhere to protocols, so they won't prescribe them a certain medication or refer them to a clinical trial. And that kind of results in this unequal shared decision making and fewer invitations to participate in clinical trials. And I don't think that we can fix the inclusion issue without also addressing the bias issue, conscious or unconscious. It just shapes who gets offered trials. But this isn't about provider level issues or unconscious bias. It's also structural. So from who gets funded, who designs the trials, who's eligible to participate, where the studies are located. As I've mentioned over and over and over again, we've sort of normalized a system that works for the few and not for all. And I think that this can change and should change. And so what can we actually do about this? So there are some great ideas and some evolving ideas and success stories for how we might be able to kind of push this conversation forward. So, one bright spot, I think, was the COVID-19 vaccine trials. This was a moment when research was designed to be accessible, and then you saw that people really did participate. So the COVID-19 vaccine trials were some of the most inclusive trials in history, not because like the science was different or the approach was different, but it was because the recruitment was very intentional. The NIH and this Operation Warp Speed, they set explicit diversity targets based on disease burden and population demographics. So they looked at who was sick and they intentionally engaged with those communities. The Moderna and Pfizer trials, they actually paused enrollment at one point to boost participation from Black, Hispanic, and Native communities. So they paused everything to make sure that they could have representation from those groups before moving forward. Most of these trials were held at community hospitals, FQHCs, and urban safety net centers, so not just academic hubs. I think that's really important, is that a lot of times the research is done where the researchers are, which can be hard for people to engage. And there, these trials had accessible trial designs. They had mobile units, flexible hours, translated material, just to make sure that they were intentionally engaging people that needed the help the most. And then there was public tracking of demographics, and we talked about it every day, all day. The science was moving so fast, and that sort of ensured accountability. So again, these trials succeeded because the inclusion did not happen at the recruitment table, it happened at the design table. So from the very beginning, there was a discussion about how to be inclusive and who was participating in these studies. So that sort of informed where the study was held, who was eligible, what language the materials were in, who was on the team, and then what kind of support services could be offered to ensure that people felt supported and included. So logistics really matter. We can't expect people to participate if it costs them too much time, money, comfort. I know Peter has a lot to say about this. I would love to hear, Peter, your comments when I'm done. Solutions like offering transportation assistance, childcare stipends, flexible appointment times, all of those things are really important. I think it's important to also recognize that the IRB says that you can't offer too much money because it might be coercive. So there's this sort of imbalance between the policies and what we know to be effective in engaging vulnerable groups. There also needs to be support for clinicians, so giving them time and the help they need to offer the trials meaningfully. So it's a both and approach. That might mean dedicated research staff, embedding trials into everyday workflows. This is something that, again, is being discussed right now at the university level. How can we increase participation in clinical trials? What do providers need to make sure they're offering and they're aware of what to offer to everybody? And then how can we make sure that patients have what they need to say yes? This is about trust building. I think that, there needs to be trust between the patient and advisors, or I'm sorry, between the patients and the researchers, in order to make sure that people feel comfortable saying yes to engaging in clinical research. So this means being transparent about what the research objectives are, the risks and the benefits. So ensuring that patients fully understand the purpose of the research, potential benefits, risks involved. This is pretty standard IRB expectations. But by being transparent, researchers can build trust with the participants and sort of alleviate any concerns about the research process. People have found, and I'll give an example of this in a second, that some of the best ways to do this involve community ambassadors, so people who can vouch for the study and the team. You can explain all day long to somebody what the risks and benefits of a study are, but it's often more effective if that comes from somebody who they already trust and who's already a part of their community, who's a leader who can serve as sort of an intermediary between a researcher and the community, helping the communities realize the importance of the researcher and vouching for its credibility, and showing participants that they have a voice and a stake in the outcome. So these are some of the more successful approaches to ensuring participation in clinical research. We can think about how we talk to patients. A lot of patients are open to trials, but they just don't know that they exist. So bringing trial awareness to the clinical routine, I think, is very important. This was sort of a figure from a paper that I was reading that it was very pretty and offered a suggestion about how you might be able to do this. So it could be simple. It could be something really simple, like asking about trial interest during check-ins, offering materials in the waiting room. We have discussed, a TWISL pathway in which people sort of agree to be approached prior to their clinical appointment, partnering with trusted organizations, churches, barbershops to reach people outside of the hospital. I think that's very important, and compensating people for their time. So awareness is enough. It's not enough to be aware. You really have to remove the barriers to saying yes. And I think this is the point. This is an important point. It's not just who's in the trial, it's about who's designing and leading the research and who's asking questions. So when you have a diverse representation on your research team, diverse researchers bring different questions, methods, and priorities to the table. I think it's really important to not only fund, I think it's important to fund a broad range of researchers at various stages and from various backgrounds. Diverse researchers are more likely to focus on health issues that affect them and their communities and to build trust with participants who often feel overlooked. Representation really matters in the lab or in your own lab just as much as it does in the clinic. This is another community engaged strategy slide. This is an example I wanted to talk about some work that I'm involved in with IU Health. There's a initiative called iHeart, which is it's a cardiovascular risk reduction intervention that's taking place in the community in 3 high-risk Indianapolis neighborhoods that are marked by high rates of cardiovascular disease, socioeconomic vulnerability, and access to an IU Health clinical site. So one of the projects that I am involved in is called Barbershop 2.0. So Black males have disproportionately high rates of cardiovascular risk, including high blood pressure, and often are less likely or the least likely to have a primary care provider. And so we thought that there's been research to show that when you bring cardiovascular care into the community, into trusted spaces, that people are more likely to be engaged. And so while this isn't a clinical trial, I think it's very important to show what community engagement can do. So there's a barbershop called All on the Wrist that's on 22nd and Meridian, and Marvin, this is on the upper left-hand corner. It's owned by a man named Marvin, and he's become our community ambassador. And the picture below him shows an IU Health nurse who is in the barbershop periodically that screens patrons for blood pressure and then makes referrals on site. There's also a community health worker that screens for social determinants of health and connects them with resources that they need. Marvin goes into the community to recruit people to these these blood pressure screening events. And he also explains the value of the program to people as he's cutting their hair. And we have found that over 40% of people who were screened with high blood pressure in this setting had no prior awareness to having high blood pressure before. And so I think it's a really important example of what you can do when you engage the community in a trusted space that doesn't include asking them to come to an academic medical center to participate in research. So translational research is a good bridge from bench to bedside to the community, but we're not, in order to do this equitably, we need to shape the systems, build trust, center justice in a way that sort of moves science forward. And that's sort of the equity piece in clinical research. So in summary, representation in research is not just a box to check. So there's a large proportion of the US population that remains excluded from clinical research. These same groups often face the greatest health burdens, and clinical science can't serve the public unless it reflects the public. And improving representation is very, very important, and it is not a box to check. It requires investment of time, trust, money, transparency, accountability, and is the responsibility of all of us. So those are all my slides, but I'm hoping that we can chat.
Thank you so much, Dr. Cheng. Actually, why don't we just all go by first names? Erika. I know there are many people on this call. I'm seeing some names here, people who may have questions. So let's let them go first before I start yabbering, because I will yabber. You know me, jabber. I will jabber and I will yap. So anybody just jump in, unmute, and ask your question.
No questions.
I'll start.
Yeah.
I'm sure people will jump in, but interrupt me if you were just about to come on. So, what was I going to say? I mean, I think that in some ways, what's really fascinating about your talk and about this set of issues is that, there's a cynical way to say it, and here's the cynical way: is who does this benefit? You've presented. Oh, Tracy, you're on video. So, Tracy, maybe you want to go first. Do you want to go first? Can you? Okay. Well, I'll go ahead and ask my question. So there's a cynical way to ask this, which is that, the interest in getting people into clinical trials overall is actually an interest of powers that be, powers like this med school, like a Lilly. We say most trials do not complete, and many trials do not complete due to lack of recruitment. And so we say this is about inclusion and representation, but this is really about, there are great efforts at the med school, IU Health, institutionally, so it's wonderful. So that's a concern. But the way I'd like to say it, I can flip it. I wonder how you think about this as actually a different way to frame the entire conversation, right? The way you did, I thought, which was this is about increasing enrollment and doing that in an ethical way. So you increase it across the board, but it's about increasing enrollment, which is actually something we're all, science is interested in, and the concerns are those of the Belmont report, like, increasing enrollment at the cost of individuals. But if your goal is increasing enrollment, getting trials filled, as you said, you should look everywhere. When that's efficient. Sometimes it's not, but when it's efficient, and there are ways it may be more efficient than we think to get people from all corners, rural, city, all ethnicities, all races. Then it's a push to succeed in clinical research overall, rather than a focus on just representation. Is that how you've migrated, and is it the political climate, in part that representation has become a politically charged topic? Let's just say that. Whereas this is actually a non-politically charged thing to say. Like, we want research to happen, so let's get everybody in.
But I feel like that could potentially run the risk of that's not really addressing the problem, potentially. I think if you are given the charge of being more, we want to get more people involved in research so that the trial doesn't fail because there's under enrollment. I don't know that people's first reaction to that would be like, okay, let's, engage communities that are harder to engage. Let me apply myself a little bit to understand why certain communities might be reticent. I think it's more like, oh, well, maybe I can look here instead of here for the same people. I think it needs to be intentional. It needs to be intentional in terms of it's not
Yeah,
always the easiest thing for people to do.
love it. I'll step back. Thank you. Good answer. A lot of tension there. It's not that they align easily. It's that there could be tension between the two.
No, and I wonder, how I presented data that has been sort of not changing for decades in terms of disparities that we see and who's involved in clinical trials. And it's not just a race difference, it's also an economic difference, a location difference, a language difference, lots of different kinds of disparities. But now that we potentially might not be required or allowed to report on differences amongst groups, I am concerned that there won't be a momentum to improve the disparities in what we're already seeing.
Hey, Erica, this is Lauren Nephew. Can you
Hi,
hear
Lauren.
me?
Yeah, hi. You gave this talk last year.
I've given this talk before, but I always like to hear it because it's a topic I'm passionate about, and I want to hear different ideas. And it was a great talk. Thank you for giving it. And I wanted to get you talked about kind of the different at different levels, all the things that are likely needed to help um, participants to be able to engage. And we both do this work, and we know that it is expensive, time consuming, and requires expertise. Like being intentional about diversifying your clinical trial enrollment isn't just like intuitive, knowing
Mhm,
how to approach the populations. It takes time, it takes money, it takes expertise.
mhm,
How do we get people to invest in that unless you just happen to be someone like us who does this work?
mhm.
I have
Like,
a thought. I mean, I have my own ideas about the
I love,
likelihood that anybody's
I
gonna
know.
really do this because it's the right thing to do. But how do you get people to, it's just easier to do the trial at the university hospital and to enroll the people who are in your clinic and to stop enrolling when the clinic closes at 5 o'clock. It's easier, it's cheaper, and
Mhm,
nobody's stopping that from happening. How do we
mhm.
change that?
I mean, I worry that like we are going to be sort of stunted in our efforts to do so. But I would love to hear what people think about that. I mean, I think us all on the call, we can all agree that there's a moral, ethical reason to try harder. But I agree there's no accountability. I mean, I think that that's what I was kind of talking about with like the Belmont report, like how like the Belmont report does a really good job about saying like you can't do harm in these areas, and like the common rule being like these are the things you can't do. And I mean, maybe it's going to take sort of an evolution of those rules, like an update on sort of those rules, and to broaden the perspective of what, how we should be doing this work in order for people to do it. Because I agree that people aren't necessarily going to want to do it just because they should. Do you have any more ideas, Lauren?
Sorry, I had to unmute. I think I think somebody's got to make it a requirement.
Mhm.
Now, who is debatable? Is it the IRB? Is it the journals? Is it the grant funder? Is it the institution? Is it all of the above? Um, because I just don't think we naturally do things that are harder just because and cost more just because. A lot of the things I do, of course, I want to take good care of patients and I want them to understand the study, but the IRB makes me do a lot of things.
Mhm.
you know, because if I don't have these things in place, then they're not going to let me do my study. And so some of the things I do is because it's the right thing to do, and some of it I do because the IRB tells me I have to do it, and I just do it.
Well, and some of the
So
things too are like we don't have anybody on the team who speaks Haitian Creole, so we can't include participants who speak Haitian Creole exclusively because we actually can't communicate with them, and that makes it extremely hard. Or a lot of times we exclude people with disability because we don't have we can't afford to accommodate everybody, and so that
right.
it's not like it's done with ill intentions, but it has an effect in that those populations we don't know as much about um, how to intervene. This is
I just think everybody has to be involved at all levels. There has to be some expectation that you're not going to hit every minoritized or vulnerable population, but for certain things, it matters more. For cardiovascular disease, it might matter more. For certain populations, for breast cancer, it may matter more, depending on where your study is. There's got to be some impetus at all levels for journals to just say, well, I mean, you didn't even make a table one that tells me the race and ethnicity of the people in your study. Like this is just not even an acceptable publication.
right.
Or, I funded you for year 1 and 2, and your enrollment is below what we would expect to study this population. Either get it up or don't get the rest of your money. Like there's gotta be some small safeguards in place that just aren't, in my view. But
It's, yeah, it's really interesting. So we wrote a grant recently to look at GLP-1s, so like Ozempic, Wegovy, amongst adolescents, and which has recently been something that's been FDA approved based on the really stunning results from a clinical trial. And when we looked at that clinical trial, 78% of participants were white, and they were all from upper SES. They were all well resourced, and so we made there was the FDA made like a broad recommendation to everyone in the United States based off the results of this like quite narrow population. And I wonder if anybody at the table raised that as sort of an issue that should be addressed. Peter, do you have any other thoughts? You have a gift of gab.
I was gonna chime in, Erica. This was amazing. Loved it. When kind of piggybacking off of what Lauren said about like this is really expensive, I think that there's just a lot of mistrust in communities of like the power structures, Peter, you were talking about, like the Lillies, the IU Healths, the giant like institutions. And there can be a lot more done from our institutions to engage and garner trust in these communities before research begins. I kind of consider research like dating, right? You're not going to go all the way from like, hey, we're engaging with you. Do you want to do our research project? But like, if our institutions were spending the money and the time to actually like engage with these communities, it would pave the way for researchers to come in next and kind of have a relationship to stand on with the people that we're trying to communicate with. And I think that that's something that would take off some of the costs that we bear as researchers. And I don't know, I feel like looking at the budgets for some of those organizations, they might have the money to do stuff like that, that could be like actual worthwhile work for all of us, not just research for clinical care too.
You want to respond because I like to respond. I think you're right, Tracy. In fact, Silk Soto's data on this, which I think is, she may have been citing somebody else, was, you ask, say, a Black patient why they didn't enroll, and they don't say Tuskegee. They say the way I was treated at clinic or the access I have, and the fact that I got a copay that's breaking the bank. So then it makes it's a more holistic approach to the problem. It's about trust in institutions and health of the healthcare system, but that also makes it a problem that's enormous, right? Right, too big to solve. So I do think again that gets back to the issue of which problem are we solving, and I guess the recognition, as always, these are interconnected issues. The way we provide healthcare and the differences in health between the communities and populations in our society, and then the ability to research that might actually improve that health. Because actually, I must say, Erika, the iHeart study is so impressive and inspiring, and getting people involved in that project and getting them the care that will make a difference in their lives is inspiring and important. Getting those people to participate in clinical research, I am less inspired by. I mean, unless it's research that brings them something valuable. So maybe that's a leftover from the Belmont report, seeing participation in research as a burden rather than as an opportunity.
Well, I was hoping that you talk about that a little bit, Peter, because you have, I think, a very great perspective, potentially unique to me anyway, about how clinical participation in clinical research is not necessarily a gift. So can you just talk about that for a second?
Yeah. Yeah, no, again, you've had the pleasure of hearing me go on about this.
I like it though. Yeah.
Is that, in clinical, in the settings you and I and many people on this call are commonly in, we recognize research as being essential and important. We think of the participation in research as being a benefit. But of course, it's not always, right? It's a burden to be part of research. Often, you're part of a phase 1 trial where you're getting escalating doses of an unproved medicine. That's you doing a favor for the future of society and the future patients and for the researcher. It's not a benefit to you. And so when we say that, like, boy, we need to build trust to get more people to participate in that kind of research, I think, not sure that's what I really want to be selling, because then I'm selling them to something for somebody else. I'd like to encourage those who would like to do it, but I also don't know if it's everybody. The other thing I was to say, to my final point on this topic, would be that when you say offering trial participation, that was a term that came up, I think, multiple times in your presentation, and certainly in Lauren's presentation last year, and the way we think about this. But that is a multidimensional, right, concept. What is trial participation? What is the burden? What is the pay? What is the benefit health? And what are the risks? And that's of course what's going to have to be split up and thought about on an individual basis rather than just overall.
And what do you think about incentives for trial participation?
Well, I'm actually thinking we're going to do. We do need to invite the group here that's funded Sarah, and I'm blanking on her last name, who runs that big grant on with David Haas on and that whole group on doing research with pregnant patients. So I'd like to hear an update from them on how they're doing with that challenge. We of course I've done a talk about learning healthcare systems and enrolling people, in a way that wouldn't really look like our current way of enrolling. And of course, I've done a talk, and you've heard, and we've done in classes about paying and how much is enough when the benefit is not there to the patient of the participation. Maybe then we should talk about paying well, because paying well is an ethical way to treat people. It's often framed in traditional research ethics as being coercion to give people lots of money to participate. But as some people know here in some of the classes I've done, we've talked about how is that coercion or is that actually, proper reimbursement? But
well, if you think that what you're doing has a benefit, then how are you? I mean, coercive is very negative. And I think it sort of sets the stage for, I'm trying to bribe you to do something that I wouldn't do myself, which isn't how I went to think about clinical research. I would also be interested to hear about the pregnancy study. When I was pregnant and breastfeeding, I'll tell you, I couldn't get any clinical care at all. I couldn't even get an allergy test. Nobody would do anything because they said, well, we have to exclude you from treatment because there is no evidence to ensure your safety.
yeah. Good. Okay. Others on these questions. We also have a talk on rural enrollment and research. It was given by Dr. Kathy Head about a year ago. Maybe it was 2 now. We'll make sure we link these on our website if people want to explore these issues of diversity and enrollment and inclusion that we've been exploring through the CTSI program over the years. I guess I'll say one thing. Erica and I are running a program for this clinical research initiative going at the med school and IU Health. And we did go back on data of enrollment in clinical trials. And the data you showed, Erica, was very good, I thought, in that, is that a glass half empty or a glass half full? And of course, the usual answer is both, right? So if it's 16%, if it's 9% of participants are Black, and it's 16% of the population, is that good or bad? It's not as good as it could be. It's also not zero, which is wonderful, and it's probably been increasing as you showed in your charts. So I think we're also it's a matter of trying to improve rather than say start from zero, which is good.
Well, it's interesting too, because I think what Peter and I are involved in is the goal is to increase participation in clinical trials at the Academic Health Center. It's not to improve representation or ensure equitable representation in clinical trials at the Academic Medical Center. And I often feel like a thorn in the efforts by, sort of raising my hand and Peter raising his hand, being like, well, what about, so is that, is increasing, I agree with you, Peter, like is increasing representation as a whole, it's a good thing. Yeah.
How about this way of saying it? Increasing representation as a whole is a good thing. But what we really are, the North Star, right, has to be improved care and health
For everyone.
for everyone and for diverse populations. And if that means better research, including people, as you said, I think you were going to say, Erica, like studies that enroll, 100% African American patients, studies that are actually, how do you consider that study? Is that an overall win for overall representation, or is that almost like a corner? Well, it depends on how that study will contribute to care. And to be honest, that study might contribute to the care of African Americans better than increasing the participation in some other study by 3%.
Right.
If the finding of that study actually will change the care of African Americans, or the finding of a study with all pregnant women will change the care of pregnant women in a positive way, then that's a payoff. And it's not really just looking at the number of people participating as an overall picture, as a percent. It's really about understanding and pushing forward with research that makes a difference in the care of our population. So anyway.
And I agree. No, I agree. And I agree with Lauren that there needs to be somebody accountable. There need to be more NIMHDs out there. So we'll see.
Now that,
Oh.
yes, other people to speak, please.
No, I was just gonna say I don't know about that one.
I know.
I know. But I think in some ways believing that NIMHD is gonna somehow cure all the problems. Not that that's what you were saying, but I do think some people say, well, NIMHD will deal with that. NIMHD is gonna do the health disparities work. Where really you want NIMHD, but then you want everybody, right? You want you want any, JAMA and NAJM and all the other NIH institutes to be thinking about their role and their part that they play in this, and you need NIMHD. So, but
Yeah,
we'll see how the next
we
next
will.
4 years go. Yeah.
Well, thanks everyone. I appreciate it.
So the downside of being on video is we don't clap really, but
I don't want anybody to clap. Okay.
Erica, thank you so much for this presentation. Again, it'll be recorded. It'll be on our website. We'll link it to our other web topics, other talks that we've had on this related topics. And we'll see everybody for Colin's talk in a month, or is it 2 soon? We'll send around a reminder to people who are here about diversity in genetics research and differences in way of ethnicity and race actually affects diversity in the genetics that are found, at least to one sentence description of a complex topic. So thank you all, and take care.
Thanks, Peter.